So, welcome guys. As many had requested to start a session based on our Zainam schedule, I'm just I came up with the idea of doing this kind of sessions. It's completely going to be PYQs, and for the last 4 days, ma'am has given a schedule that's completing anesthesia, ortho, ENT, and psychiatry, if I'm not wrong. And today is a buffer day according to ma'am's schedule. So on this buffer day, I wanted to start this PYQ series by discussing anesthesia, ortho, ENT, and psychiatry. And it is going to be sessions of maximum 10 to 15 minutes each. I'm telling maximum. I don't want to take much of your time ahead. So, are these are many questions came from your side, and I thought that answering here will be much better. So, everyone asked me that whether it's going to cover all the PYQs. No, it's not going to cover all the PYQs. Whether it's going to be same as your all PYQs, definitely not, and it's not needed, and it's definitely not at all needed. And whether it's going to be as a rapid revision, no, not. So what it is? So it's completely dependent upon your probability game. Just a probability, just a probability. So according to this, my assumptions will be: see, for if you are doing anesthesia, my focus will be on the PYQs based on, see, we have some 12 to 15 topics in anesthesia, but my PYQs will be focused on only 3 to 4 topics. That is most important ones like your IV anesthetics, airway management, or maybe any important monitoring sections. That's also these 3 to 4 sections is called as PYT, and these PYTs need to be touched day before exam. Okay, so this is something is very important, day before exam or maybe weeks before exam. You can put it either way, weeks before exam. Okay, so on this note we'll get started. Hope it sorts your query. Okay guys, so first question you can see, so November aims PYQ. Yeah, hope my PDF is clear to you. So in this question you can see this: a patient is put on a ventilator. He gets agitated and pulls out his tube. Yeah, so this is a typical case of your accidental intubation. So two scenarios can come here. One is accidental self extubation or homicidal. That scenario is also very common in our government settings. So what are you going to do here? So in this thing, definitely you can sit up and do chest physiotherapy. No, it's not our job. So that itself rules out. Wait 1 second. So that itself rules out our option A. And definitely reintubate. No, it's something basic common sense because he's in a ventilator and he's agitated, so we can't do option D. So what the now the confusion lies between B and C. So how do you choose this? So it's also basic pure common sense. See, already he's agitated and we don't know what is the reason for this agitation. So that could be because of any pneumothorax or hemothorax or any emergencies. He can have any emergencies. So without ruling out any emergencies, we can't directly go for blind ventilation. This is very important. Never do blind oxygenation. Okay, so this is something basically common. So you can clearly see it's face mark and 100% oxygen. No, I'm sorry, we can't do it. Okay, because he's agitated and we don't know what is the reason. No, so we can't do this. So we can't do this. So ultimately, give bag and mask. So and reassess. The reassessment is very important. And for the same reason, that is becoming an answer here. Okay. So your option is option B here. Got it. Yeah. Hope I am clear. Next you can see this. This is a very interesting question. See, arrange the steps of intubation in sequence. It's nothing. It's also the pure common sense. See, definitely neck has to be extended and then it should be flexed. Okay, first you have to do extension, followed by that you should be doing, why, what is happening with my pad? Okay, so first you have to go for extension and then only you should be going for your flexion. This is something very, very important and which we all will be making a mistake here. And then we should be having a laryngoscope, and then you have to fix it by inflating the cuff, and at last you are going to check air entry by stethoscope. Okay, so this sequence is A, B, C, and D. So this is very, very important. Never confuse between C and D. Okay, it may, when we are recollecting, it may think that we have to inflate the cuff after checking the air entry. No, that's not happening. Okay, though it seems sensible, that's not happening. So the option answer is A, B, C, and D. Next question. Yeah, this is something which is out of our hands. It's coming under NORSET, that is nurse examination conducted by AIMS. Maybe they should know it, but as a doctor, we also should be knowing, I think. So that's why they have just asked it. What is the time for which a nurse should do suction in intubated patient? So this is something 10 to 15 seconds, and it should be periodical. Okay, not an one-time thing. It should be definitely your periodical stuff. And next, coming to your during laryngoscopy and intubation procedure, uh, all of these are true except, see, definitely this pressure need to be given. Definitely, a neck is flexed, extended at Atlanta occipital joint. Okay, this is kind of not a full answer, but half answer. Okay, next, after insertion of laryngoscope, it is levered on upper incisors to pull up the tongue and visualize. Yes, obviously we are doing it. So now the confusion lies between option B and C. Option B is held in your right hand and introduced from your right side of your patient. Entirely wrong. Okay, so whoever, whatever hand you have, right, you are, whether you are a right hander or a left hander, you should be holding your laryngoscope in your left hand. Okay, so whatever may be the handedness you are having, that's not going to matter in front of the patient. Okay, then there is one question here. If the doctor is single handed and he's amputated, or the doctor he himself is having a hand is not functioning, so in that case, what is the preferred hand for doing intubation? So 5 seconds quickly. See, no. So first of all, we should be knowing a doctor shouldn't be amputated. He's not physically fit to carry out the medical profession, so he's out of it, and he's not asked to do that job again. So this is something basic common sense. This they can ask in the same way, but in a different application. They can ask this question. Okay. So next question: identify the use of the instrument. Yeah, it's obviously a laryngoscopy. This kind of spotters. Basically, your airway devices and spotters are super important. So this is something I felt that I should be mentioning. Just I don't want to go into the much details of it. So only one thing: oxygen delivery devices. Two things. One is has to be your variable performance device. Another one has to be fixed performance. So whenever your fixed performance, there is going to be a controlled FiO2. Whenever there is a controlled FiO2, patient independent, because regardless of whatever you are going to change, the patient will be should be maintained in a constant pressure. So in that thing, you should be going for this fixed performance. So patient independent is what? This fixed FiO2, fixed performance delivery devices. That's only one thing, Venturi mask. And you can remember, Venturi mask has that rigid tube. Okay, so it is rigid, it is fixed, but it is patient independent. Okay, irrespectively, it is developing the same thing. Exactly opposite is our variable performance, because according to the needs we can assess it. Okay, so here you can see nasal cannula, prongs, face marks, and reservoirs. So everything will be having it. So this is very, very important. So next, coming to this, yeah, this spotter is also very, very important. Fine. So what is it? So this is nothing but a basic capnograph. Okay. So let me put this. The capnograph is there. Okay. So what is a capnograph? And also, where will you do it? Okay. So this is something I wanted to ask you. Capnograph, everyone is focused on the spotter's point of view. But if I am asking what is a capnograph means, what are you going to tell? It's a graphical representation of CO2. That's all. So it's a graphical representation of your CO2. That's all. That's why we are having this. And where we are seeing it, these are all its pure basics. We should be seeing it in a ventilator. Okay, we'll be having this in a ventilator machine. This is also pure basic. And this is a normal capnogram, and the spotter is very, very important. So at 0 mm Hg of CO2, we'll be having respiratory baseline, expiratory upstroke. This is your alpha angle, alveolar plateau. There's a beta angle. There's an inspirated downstroke. Don't get into much details of this thing, but the spotter is very, very important. So there is a respiratory base, expiratory upstroke, not inspiratory upstroke, because it will, recollect, we tend to make that mistake in exam. So expiratory upstroke followed by that this and inspiratory downstroke. So this is something you should be doing. And the third phase is our plateau phase, alveolar plateau. Okay. So next you can see this curare notch. Yeah. So next image. So next image is pure curare notch. So what does it tell? The patient is reattempting, just a reattempting. That's all. Okay. Just a reattempting ventilation. So he's having that. So it indicates that the dose of the muscle relaxant has to be increased. Because why muscle relaxant? Mainly your diaphragm and your intercostal muscles of respiration. So that needs to be relaxed again. So next you can see this is an example of your biphasic curve. So it clearly indicates it's not a single thing. Okay, so normally it has to be somewhere like this, but here it is biphasic. So biphasic indicate only unilateral functioning. Okay, so unilateral functioning. So all the conditions you can suspect here. So that can be due to kyphoscoliosis, air leak, endobronchial intubation. This is very, very important, and single lung transplantation. This is expected. Got it. So next you can see this. So this is elevated baseline. See, the baseline is elevated. So whenever your baseline is elevated, this is because of your exhausted CO2 absorbent. Okay, so it's purely because of your exhausted CO2 absorbent. So this is very, very important. And next you can see this increased alpha angle. Okay, so this is simple, like it's increased alpha, and you can see what is alpha here. So increased alpha, since alpha is getting increased, we are having this kind of direction, not this kind of direction. So this increased alpha, it is seen in which indications, especially your COPD. Okay, COPD is very, very important. Same followed by your bronchial asthma is also very, very important. And also any, you can suspect blockage of secretions, any blockage, whether it is a pathological blockage or it is an induced blockage, that is any blockage. Okay, so this is very, very important. So foreign body, blocked ventilator tube, blocked bronchi, blocked trachea, everything is going to show this. So next you can see this. So increased angle. So our first one is increased alpha. So that's why our curve is shifted this direction. But here it is this direction. I mean, this angle is the increase. This is nothing but your beta angle. So whenever your beta is increased, just remember beta for breathing. Okay. So this is for your rebreathing. So patient is rebreathing his own air again. So that's all here. So this image. So this is pure. You can see a downward sloping. So he's going for your arrest, embolism, sudden hypotension, death. That's all. So next, I've just eliminated the question here. So it's pretty obvious. Just it's an example of your curare. Increase your muscle relaxant. Yeah, this is very, very important. See, this is bifid. We'll be calling many shark fin that fin and all, but it's not needed. Whenever you see a biphasic that is not uniform, okay, that is not uniform. So definitely some unilateral entry is going to happen. So from this itself you can see bronchus is above, so it is going to have by both will be involved. Breathing both will be involved. I mean it will be big, increased beta angle will be there. Leak from your expiratory valve, no, it's not needed. Okay, so here it is right-sided bronchus. So this is your answer here. So your answer is going to be right-sided bronchus. So next you can see this. Preferred site of core temperature. This is also very important. Distal esophagus. Nothing more to explain here. This is important. Correct sequence of your alveolar concentration. Minimum alveolar concentration required to induce the effect of drug in the patient. So what are we going to do here? So it's pretty simple. See, remember, neonates have decreased MAC. Neonates have decreased MAC. Okay, but your infants have more. Okay, infants have more. Okay, and your adults followed by that. So this sequence you should be remembering. You shouldn't confuse between your infants and neonates, because in some things, some textbooks, it is given neonates more than infants. No. Okay, and it's a PYQ, and we better stick to it. Infants followed by neonates is our answer. So this is what I was just trying to tell here. Okay, so you can see it is decreased, and then it is increased, and followed by that it is going on a decreasing phase. Okay, so which of the following is can be used as a next, coming to our last topic, that is IV. So which of the following can be used as an induction agent? Yes, Dex. See, mostly for your IV anesthetics is content, you will be getting only one question, that is from your ketamine. You can expect that as a rule of thumb. But here we are just focusing on your what are the other possibilities we can get. So this is something Dex merotomidine. So what is it? It is a highly selective alpha 2. Okay, alpha 2 agonist, and you know that alpha 2 agonist has a inhibitory action, so it is going to produce sedation, hypnosis, analgesia. Okay, and it is going to act where? Okay, it's more which mainly it's going to mediate in your locus ceruleus. Okay, so this is important. This is a very important point, and it is used in a combination, and it blunts the hemodynamic response, such as hypertension or tachycardia, that is induced whenever you are intubating. No, so that thing, hemodynamic control. So one point, alpha 2 agonist, that you should be remembering. Another one is our hemodynamic control. So these 2 points are your main focus MCQ points. Okay, so main focus MCQs, not that much explored in NEET and other examinations. So this is important. So next, coming to your pregnant woman, placenta previa. So what are you going to do? Same, hypotension. Go for our friendly drug, ketamine. Always ketamine, unless said otherwise. So it's Hoffman elimination. We know it is atracurium. Okay, and that mast cell response. These and all will be your side effects for it. And allergy in intermediate perioperative is most commonly due to what? This is very important. See what they are asking. Immediate perioperative period. So immediate perioperative period, if they are asking that, it has to be your neuromuscular blockers. Neuromuscular blockers has the muscular weakness, sedation, malaise, and liver toxicity. So these and all will be seen in your neuromuscular blockers. So immediate perioperative means you have to go for neuromuscular. And then all are drugs acting on neuromuscular junction except, okay, this you can see. Pancuronium, succinylcholine, yes, they are NMG blockers. But dandrolin, what is the mechanism of action for your dandrolin? It is your ryanodine receptor blocker, right? It is an ryanodine receptor calcium channel blocker, it's basically. So that's all. So we are done here. And the where is this receptor present is present in your sarcoplasmic reticulum. So we are done with our anesthesia. That's all. Thank you. And these are most probable topics, and the topics I have tried to cover here is your airway management and your IV anesthetics and your monitoring. Mostly focusing on your pre-op, peri-op, and your intra-op and post-op. So these monitoring sections I have just tried to stress here. These three are your most probable topics, and I can't tell it will be 200 percentage from this, but it will be surely. What can I say? Out of 200, you can expect 130 to 140. Okay, from these probability will not fail us. Probability won't fail us. Won't fail. Okay. Thank you guys. Not taking too much of your time.